Last year alone, over 100,000 people lost their lives to opioid use. That's 1 in 5 every 24 hours. Hi, I'm John Houle, and I'm here with Linda Hurley, President and CEO of CODAC Behavioral Healthcare. Welcome to our first edition of CODAC Live. Welcome, Linda.
Thank you, John.
That's an alarming statistic. In fact, the President in the State of the Union addressed opioid use dependency and talked about how he's making it easier for doctors to prescribe medication. What are you seeing out there? Why is this such an alarming statistic? What's happened?
There's actually been two developments. One, I believe most people know about, and that is the tremendous lethality or the deadliness of the adulterants that are in street products. So if someone has an opioid use disorder and they're purchasing the opioids they need to not be sick on the street, they have no idea what's in it. And that's always been the case, of course. You know, the FDA doesn't approve, what somebody's making in their bathtub. But the introduction of fentanyl has become a remarkable risk for people that are using. And we're seeing overdose rates go up because individuals don't know what's in the product they're buying.
So is this why, for treatment use, why medication is so important?
Absolutely.
And in particular, and it's evolved over time, methadone, and then there are some more modern medications. Could you talk a little bit about that?
A lot of people are aware that methadone is proven to be the gold standard for the treatment.
And for how long would you say it's been that gold standard?
As long as it's been since the 50s.
Really?
Wow.
Methadone
has been one of the most researched pharmaceutical products
really
in the history of the FDA. Yeah.
Is it because it's so prevalently used?
I frankly believe it is because of community stigma.
Really? And you've seen that recently. Why is that? Why people just don't understand?
I've been doing this for decades now, and I really do believe that it is a critical point when individuals are looking at this disease and they're saying, well, Linda Hurley didn't choose to have cardiac disease, or, John didn't choose diabetes, but, someone else, my son, my brother-in-law, my son-in-law, my daughter-in-law, they chose to use this. Well, it's true. Volitional, it is a volitional choice when you first start to use. But we have different predispositions, so that my sister and I could go away to college our freshman years, same place, same time, same upbringing, and do what the kids call partying. They still call it that. And my sister says, I didn't do so well this first semester. I'm not gonna do that. I'm really gonna focus on my studies. And I can't stop. And that's called predisposition. There's something in my brain that makes me predisposed.
And that doesn't make you a bad person.
No.
It's not a failing in life. It's genetics, right?
There's 3 pieces to it. It's genetics. It has a little bit to do with what we are taught. And then there is some physiological issues that can happen after birth that aren't genetics that can also contribute to having this predisposition. And then once you get it, I've often heard it said that, and I like it, actually, I like the word, I use it, is that the brain gets hijacked.
Yeah. And
that's what it is. It's like, have you ever heard somebody say, it's so sad, he or she's so smart, why do they keep doing that to themselves? Or, I know she loves her children. Why does she keep doing this? She's going to lose them. I hear these statements over and over, and it is because this part of our brain, it's called the prefrontal cortex.
Sure.
But it's where our values lie. Mm-hmm. It's where we think. It's where we're logical, and it's what makes us human. It gets hijacked by the anterior of the brain, where our survival needs are met.
How long have we known this? Because I'm just hearing this now, and I've been, I've stayed up to speed on these topics, but I've never heard it described like that. I know that, and I've come to the realization working with CODAC, that it is a disease, okay? It has treatment options, and it can be very successful treatment options. But when did we start to really understand it like you're explaining?
The medical field and the science has been around for a very long time. In the 60s, 70s, 80s, there were people like Mary Jean Creek and Loretta Finnegan and others who studied at Rockefeller University and many other well-respected research entities. But the difference with this science is that it was met with so much bias in the community. People are so afraid of this disease. And when you're afraid, you have biases. And when you have biases, you have prejudice. And when you have prejudice, you end up with discrimination. And that's what our field has been riddled with since its inception.
Linda, let's back up for a moment and let's talk about you for a moment and how long you've been in this field and what your current position is, because you're talking about things that people need to know about. You've been on the front lines, and it didn't start just recently. This pandemic has been brewing underneath for a while. Could you take us through your history?
I've been doing this work for 34 years. Actually came to CODAC as an intern, and this was my third profession. So I came to CODAC as an intern because I wasn't fully buying the idea of medicine for substance use disorder, and I wanted to understand it better. So I took an internship actually in Newport, Rhode Island, and I was hired my second semester, and I have a passion for the field, and I developed it within 2 months of that internship. When you see people's lives turn around and the excitement that they feel to have a future, it's so compelling. I couldn't leave. So I went from an intern to currently I am the CEO and president of CODAC.
And in between that, you were a program director?
I was a therapist, a clinical supervisor, program director, director of operations, COO. When the previous CEO retired, I was given this position.
So how long have you been CEO?
A little over 5 years.
So tell us a little bit about the CODAC of today, because it has changed over the years. So what does CODAC Behavioral Healthcare do today?
CODAC Healthcare today does what we refer to as fully integrated healthcare, because this disease is a highly complex disease, and this is where we started. You know, we are the expert, and I'm proud of that, in the treatment of opioid use disorder. But this is a biological, a sociological, a psychological, a spiritual disease. It erodes people's souls. It's a very, very degrading disease. And so in order to heal from it and really enjoy a recovery, we have to address all of those aspects. So today what CODAC does is, of course, we treat opioid use disorder and other substance use disorders. We do it with therapy, we do it with medicines, as you had referenced, like methadone, buprenorphine products, naltrexone products, and also, the products that are available for alcohol and other substances. We provide primary care now. We provide psychiatric and mental health care. And as we move into our larger facilities with more capacity, we're going to also be able to provide all the social service networks that people need in order to get their basic needs met and then flourish.
So we must be seeing a huge decrease now in opioid use dependency, right? And overdose deaths, right?
No.
No. Even with all this work, even with all the funding, then what's happened?
What's happened is, and this is an important piece, is that in 2015, you know that Governor Raimondo at the time created the Governor's Overdose Task Force, and her budget allowed for certain amounts of taxpayer dollars to go towards this overdose epidemic. And those dollars have worked. I heard actually from someone at a local university speaking a few weeks ago and said, what have we done wrong? Because the overdose deaths are increasing. I mean, we're having greater than 1 death a day in Rhode Island.
Wow.
Yeah, I mean.
1 death a day.
Yeah, it's tremendous. Does it impact those that live below poverty guidelines more? Of course it does. We don't have a system
it's poverty,
that assists,
right?
yeah, we don't have a system that assists people living in poverty with their health care yet. We're working on it, but we don't, as a state, you know, we're working on it, but we're not there yet. So, but it's across the board. I would challenge you to find anybody that hasn't been impacted by this disease one way or the other.
Especially in a state like Rhode Island,
Yeah.
right? So is it the sheer volume of the amount of drugs coming in here? Is that what's fueling this? And so, I mean, to combat something like this, you call it an epidemic. Is that why the numbers are so high and not going down as fast as we'd like because of what's happening on the other side, the flood of drugs coming in?
I don't really know that it is the volume. I believe that it is what we had referenced earlier, I believe, is the lethality. The substances that are getting sold on the street are adulterated with at least 48 different things now. Number one is fentanyl. We all know, you've heard about fentanyl.
Sure.
It's,
I didn't know about all the other drugs. You only hear about fentanyl. So you're saying there's sometimes 48 different components of it?
Yeah, and some of them are actually just nonsense. They don't really have an effect on the brain that makes you feel more happy, more excited, more sleepy, whatever you're looking for.
And it's all to try to get you addicted, right?
Yes.
To be a repeat customer. Yeah.
So fentanyl is number one. 6 months ago, it was released from the Rhode Island Department of Health that over 70% of the product confiscated had fentanyl in it, over 70%. And then there's something called xylazine now that you may have seen in the newspaper, I think last week. It is a veterinarian used tranquilizer, extremely detrimental. The molecule doesn't even begin to look like an opioid. It just makes you sedated. But the concerns is that the xylazine has people so sedated that they perhaps can't even move for 4 hours. So people are getting robbed, they're getting harmed, they're getting raped. This is really a horrendous thing. And we really don't even know why whoever is the marketer for this product, why they would even put xylazine in it.
It's cheaper. It's maybe cheaper than
Yeah,
fentanyl. They got a hold of it.
Yeah.
So this is scary. I mean,
Yeah.
this is scary stuff. Like you said, it's affected every part of Rhode Island in the United States. So what can we begin to do to combat it?
So what we're looking at doing now, because what we did worked. 25% of the deaths in 15 and 16 were people that had recently been released from prison. 25%. So that's when the governor gave DOC the dollars, and CODAC partnered with them to create the program at the Rhode Island Adult Correctional Institute. And we saw up to between 38 and 61% in risk reduction. Lives have been saved, and they continue to be saved. So those dollars are still valuable dollars. We need to add more dollars to what I'm going to tell you about. And treatment works.
So have you been able to take the information, the data from the Department of Corrections and the treatment and see how that can be applied to other communities as well?
That knowledge is transferable. Some of the variables are quite different. The product is so much more lethal now than it was in 2016 or 2019 or 2020.
So you're just saying it's more lethal today than it was even a year ago?
Yes.
Okay.
We need to address that. So how do we address it? We address it by assisting people who continue to use, because people in treatment don't die. Treatment is successful. So we keep what works, and now we need to figure out what we need to do to help people stay safe while they're still using. And that
I imagine could be controversial, right?
It is controversial.
But we need to look at this as a disease, don't we? Not a failing of society or of individuality.
Yes, and that is it exactly. When we talk about, well, he or she decides to do that every day, they don't. The first couple of times they did. The first couple of times that individual had a choice. But once that disease takes hold, you don't have a choice.
Like it shouldn't be a life sentence, right?
Right. Absolutely not. And so we need to help people. So one of the things that has been proven, evidence-based, 20 years worth of documentation in Europe and Canada, has been an overdose prevention site in which all the harm reduction products and protocols are in place. So if I am using it and I choose to continue to use, I'm not there yet, I can't stop, I'm afraid to stop, I can come someplace and use safely. So the equipment to use will be provided to me at the spot. It will be a spot that'll have sanitized equipment. I'll be able to check my product so I can come in with whatever I purchased, and there'll be a method by which to check the product to see what's in it. And there'll be availability of a physician, a nurse, a counselor, a case manager will all be available if I want help at any time. What we're hoping to do here in Rhode Island is to even have people be able to start medicine in real time. If one day they come in and they check their product and it is loaded with things that are not an opiate, or it's loaded with fentanyl, and they say, I can't do this anymore, I'm too scared, I don't want to die, there'll be somebody to talk to if they want to talk to them. So we are looking at doing this in Rhode Island, and we're hoping that that's going to develop. It's a proposal now. What these sites have been doing is they are run by peers. So if you can come in, here's somebody that's been in recovery for a while, and they're going to observe you if you're using intravenously. They're going to observe you if you're smoking your product. And if there's anything adverse that happens, there's going to be an immediate reversal of an overdose, and we'll have medical staff present to do that.
Call them peer recovery specialist advocates.
Mm-hmm.
And why do you think that's so important?
That's remarkably important because it puts people at ease. There's this judgment. One of the reasons, the second reason that the number of deaths have gone up, we've come to realize now, is also because of the lethality of the product, but also because of the inaccessibility of care. So that many people that are literally dying from overdose won't go to a traditional brick and mortar medical center for care because historically, even intergenerationally, those sites have not been particularly effective for them. They've learned that.
So you go to your primary care if you're fortunate to have one.
Yes.
And they notice that you're on something, but is the belief or the stigma there too that you don't want to go to your primary care physician, or you don't want to go to the ER, you don't want to go to the walk-in clinic?
Right, exactly.
So what do they do?
They don't go, and that's what happens. And so that's one of the reasons, and this leads us to what do we do now?
So what do we do now?
Yeah, and so I think the overdose prevention sites are critical.
Where are we at with that? Is that something that needs to be passed by the legislature?
It was already passed.
Already passed, okay.
Yeah, sponsored by Senator Josh Miller and others. Pretty brilliant, actually, legislation, and innovative. We're the first state in the country to have legislated overdose prevention sites. They're called harm reduction sites in Rhode Island.
So describe them for us. What will they be, and when do you think we'll see the first ones? It was legislated for the pilot to be completed and being utilized by the end of 23. We're somewhere in the process now, so we really can't say when that's going to happen. And it'll be everything you described
Yes.
previously, where you can actually go there on whatever you're taking. It'll be tested. You can get treatment, of course, if that's what you choose, but we're not looking for anyone to die.
Yeah, that's the goal of that, is to keep people alive until tomorrow. And just keep coming back as long as you want to come back. Stay safe, and we'll give you whatever you want to move towards recovery as you've defined your recovery.
You mentioned that this is the first in the country, and this isn't the first for CODAC. In fact, CODAC's been a pioneer. Can you describe some of the CODAC firsts?
Well, the medication-assisted treatment in the Rhode Island Department of Corrections is an internationally known first. And what that means is medication-assisted treatment. So we were providing medication-assisted treatment in the prison for opioid use disorder. And so we were providing, and this is where the first came in, methadone, buprenorphine products, and naltrexone products, which is commonly known as Vivitrol. It's an injection that is often used for the treatment of alcohol use disorder, but also has been found successful in certain populations with opioid use disorder. So we're providing all the medicines to all people that need them when they are committed to the prison. And that is huge because there are other prisons, other jails, other correctional facilities in the country that will provide the medicine. If someone was in a program utilizing methadone in the community, they get arrested, they get committed, they're sentenced. Many jails or prisons will keep them on their medicine, just like they keep them on their medicine for heart disease or any other chronic disease. But we allow, at the Rhode Island Department of Corrections, anybody that needs it can have it. So if you come in withdrawal, if you are committed and you have a documented history of opioid use disorder, you can begin to have treatment. And so we call it inducting or initiating people on medicine.
And then you now, through CODAC, follow them after, if they choose, right? So you don't just say, okay, great, you're out of prison. Now you can go back to your environment, and we're surprised that maybe they go back into opioid use disorder, but now you're providing the treatment afterwards as well, right?
That's actually a deliverable in our contract. And the third population that we had a huge amount of pushback in is, say someone's sentenced for 5 years and they're going to get out 90, 100 days from now. They start to have dreams, and your sister comes in and says, we're going to have such a big party for you and you're going to love this stuff out there now. It's crazy. And so it's all starting, and you can simply ask to be stabilized on a medicine before your release so that you don't have that risk. I think it's 147 times higher risk of overdose death for someone that is leaving the prison or jail across the country. 147 times higher than another person in the population.
So you mentioned that CODAC was the first in the nation with this medically assisted treatment in prisons. I'm assuming you learned a lot from that and you have a lot of other firsts. So could you describe some of those other things that you've done? Most
recently, we were the first mobile medical treatment unit to be allowed to dispense medicines for opioid use disorder.
So it's an RV.
It's an RV.
All right.
It's a 27-foot RV, and
that's a good size RV.
Yeah, and we actually have a second one started. It's going to probably be finished in 60 to 90 days. I think it's going to be 35 foot so that we can have more privacy and do more services.
Because it's like going to a doctor's office, right? It's a mobile doctor's office.
It's a mobile doctor's office with a dispensary. So you can come in, you can get your buprenorphine, you can get your script, you can get your methadone. All of this can happen for you just like you would be going to a clinic for substance use disorder.
But you're going to the people that need it, right? Yeah. That might not come to the doctor, so you're going to them.
And that is the second piece, the access issue. So we're looking at overdose prevention sites and we're looking at mobile units. We need to have the flexibility of going to individuals where they live. And hopefully we are working on this, and many organizations across the country we need to be culturally congruent. We need to when we go into a community that is Spanish speaking or primarily Asian or primarily Black, whatever, we need to be culturally congruent because people need to feel respected and understood That's a critical piece of recovery, helping people engage in recovery. And so that's what we want. We want to take culturally congruent staffing into a community through a mobile treatment unit. And that's what we're doing here in Rhode Island, in Woonsocket right now.
You know, I'm in marketing, as you know, and often Rhode Island is used as a test market to roll out products nationally. Is this a possibility that the mobile unit, especially I'm thinking of rural communities where they don't, you know, Rhode Island's densely populated. You can, you know, we don't like to drive more than 15 minutes anywhere, but when I'm thinking of people out west, I'm thinking about people that don't have that quick access to go see a doctor. Is this a possibility that it could serve them down the road, that being a mobile unit, it can go to them?
Absolutely, absolutely. And one of the goals for us, because even though Rhode Island is densely populated, it does not feel densely populated in Hope Valley.
I hear you.
Yeah, and people have
or Northern Rhode Island,
yeah,
which we refer to affectionately as the Quebec of Rhode Island.
There you are. So, yeah, so we need to decrease the number of people dying from this disease because it is treatable. It is so treatable. And so we need, you know, what needs to be addressed? Access issues, which all of the access issues can be addressed by the flexibility of a mobile unit. We need to have safe utilization, harm reduction sites. That's critical. And we need to be able to have that culturally congruent sense of non-judgmental and we understand you feeling of for people. So those three issues, those three methods by which to address this burgeoning death number, it works.
So then what's the problem?
Money.
It always comes back to money.
Yeah, it does.
So it's just funding. It's funding. Yeah, because what you're talking about, you need more mobile units, you need more safe sites.
Yeah.
That takes funding.
To be able to address these things effectively and efficiently does not cost a lot of money. You can get a wonderful 2-year-old 37-foot mobile unit for $370,000 as opposed to building a building where people won't come. You know, I'm not going to leave my community, you know, my housing. I'm not going to go away. I'm not going to take 3 buses to
or
get
you're
over
going
there.
to the nonprofit that they're already used to going to, and you're going into their parking lot.
Exactly.
Right?
Yeah. So this will work, and you know I've said this over and over because most of my job now as CEO is I am a professional beggar, and I
haven't heard CEO. Is that in your job description?
yeah, PB,
professional beggar.
Yeah.
Okay. Or we call advocate.
Yeah, there you go. It sounds better, huh? But it, you know, I've spoken with, you know, many of the people that has strong influence in the state. You know, this is a huge bang for your buck. You know,
and you've had considerable success with that. I know that there's been federal dollars that have come in. The state leaders seem to be listening to you about this. But what they maybe need to listen more, or do you need to speak even louder?
Federally, we just got another what used to be called earmark, community discretion grant. We just got another one that was initiated out of Senator Reed's office.
They get it, don't they?
They get it, and of course, Sheldon Whitehouse gets it. They really support us, and they've cleared the way for us to get federal dollars.
Are their voices being heard around the country about this?
Mm-hmm. Yeah, and you know, Senator Whitehouse did the CARA bill, the very first Recovery Act, and you know, so that, and we have great private funders. You know, I mean, not as much as the earmarks would be, but we have struggled with state dollars.
Our federal delegation across the board has been very supportive of all your initiatives. How about at the state level?
At the state level, we have received a great deal of accolades And I'm so grateful because that adds to the credibility of what we're doing. And every time someone gives us another accolade, there's a little bit less stigma in the community for, around receiving treatment and having this disease.
But awards don't save lives, right? Dollars do.
Yes, and there you go, that's it. And so that's where we need to be heard. I guess we need to speak louder. We need to make our needs understood and have those needs be understood in a way that those that influence policy and dollars understand the connection between budget and what is needed.
I've often been accused of being loud, maybe even called a loudmouth sometimes. So I think that's what CODAC Live is going to be all about, is we're going to raise our voices, we're going to be heard, we're going to talk more about difficult things. People need to know about it. And so thank you, Linda, for coming on and being the first person to start bringing this to the forefront. And I look forward to seeing you interview leaders throughout the state to talk about this, because maybe we can move forward and make a difference.
Thank you. Well, thank you for the opportunity.
Well, I'm just helping facilitate it. You're really making the opportunity.